want to thank the Society for launching with this meeting an opportunity to push the field forward. Actually, my lecture will overlap, so I'm going to cut down some time. I think we're about 5 minutes over, so we'll move quickly through this. Our disclosures, the same as yesterday. We have a credit through the government to development of the URNAV system. Again, the team here, and I wanted to highlight all the fellows in attendance, the residents and the students. You heard, people refer to that paper as the Siddiqui paper because the knowledge that we learned from each other was very important on this podium. Sarusha's here, and then the young students in the audience who will become those fellows in the future. So, listen, this is an old method. We moved on from it. I think we all believe in this as part of this focal therapy society, that imaging is the key to focal therapy. But there is no doubt that we still hold on to what we're used to. And for our colleagues over in the UK and the European Union, we do feel that letting go of the 12 cores is hard on this side of the water. But there may be some merit to that. MRI, by far, is a new era, and we can move through this very quickly. This is the paradigm for which we do image guidance. And we thank, obviously, Mark Everton's group for this. This was the definitive trial that told the world that without a doubt, what we thought was image guidance, which was ultrasound imaging, was actually a fool's errand, and MRI has the ability to see the tumors within the prostate. But so what happens now? So you buy into the fact that MRI is going to help your patients. You have a radiologist who you trust. He or she is doing a great job, gives you targets. You have a system, whether it's cognitive or software-based. You do this, and your biopsy is negative. And this is the scary part, right? Because we understand when the biopsy is negative and it's blind, we know why we've missed it. But what happens now? Well, there's two parts of this. And we were, as urologists, I would say, to take blame, that we quickly would offer the blame to the radiologist. Well, the image quality is poor, or the interpretation was erroneous. But there's a big component of the biopsy actually misses the target. And we have to own that also. So I'm going to cover both topics today in the next 5 or 7 minutes. So first of all, the MRI can be incorrect. We heard from Tom's presentation. It's not perfect. Well, actually, Dr. Barry's Turkbay and Pete Troike, our radiology experts at our institution, took 100 consecutive patients, and they wanted to see in their eyes any pattern 4 is something that, if they missed, was a significant cancer. So this is grade group 2 or higher. And the same type of stringent criterion that we've used in the past for other publications. We image at arguably the best quality the government could provide, as we say on our campus, because we have a 3T system, we have a body surface coil, we have an endorectal coil, we are in no rush, we repeat parameters, we want to fine tune this perfectly. We have a team for this that is arguably the best quality we can provide. Then we actually have a 3D printing system, an engineering group that will take the MRI, give us a pathology mold for which then we can go ahead, once I take out the prostate, step section it in axial plane, and still we miss prostate cancer on imaging. With all this, what they found was in those 100 patients, and this is at the end, far beyond their learning curve, with the technology that I mentioned, 100 patients, 162 lesions missed. Now, in the yellow, a topic for maybe later on today and tomorrow, this underestimation of prostate tumor size on imaging, which could be one of the issues we have with focal therapy and recurrences, is not for this topic. But for today, we have 16% of those tumors were missed in this series. And then the question is, what are you missing with that? Well, it turns out that the majority of them are Gleason grade group 2. And Gleason grade group 2 in some series has been felt possibly, maybe occasionally, as an active surveillance opportunity. But still, we miss grade group 3s and higher. It's a small percentage, but it's there. And this is very important to remind yourself when you do that negative biopsy. This is the paper that was referenced just a few moments ago. And yes, in the yellow bar, the fusion biopsy misses the cancer. And as you can see, as you go across, those tumors that are missed are worrisome. Now, keep in mind, we miss cancers in both modalities, the 12 cores and the targets. And yes, by far and away, if you had to miss a cancer with a technology that was either image-based, MRI-based, or systematic but blind to tumor location, you far and away will miss much more lower risk cancers. Now, as a caveat, this green bar includes GG2. And one of the big criticisms of our paper in JAMA many years ago is that we took that bar and said GG2 cancers can be considered low or favorable. And actually today we would call them intermediate favorable. But yes, the 12 cores themselves will miss more of the red and yellow higher grade cancers. And I think the other issue is the PIRAT scoring system, version 2, introduced a couple of years ago. And there's been questions about the performance of this. And there are many folks in this room who are the pioneers of this work who would argue that their system themselves is a better scoring system. But it's not universally held, and therefore we live with PIRATs. And what happens when that is the issue? Well, Barish took these patients, 62 patients, 116 lesions, all underwent biopsy. He wanted to determine if this system, PIRAT system, was actually causing problems for us. And just in general, there's this trend, as you can imagine, that a larger lesion is a more aggressive PIRATS 5 lesion, and we've seen this in lesion size. They want to look at the cancer detection rate by fusion biopsy, and the PIRATS 5 lesions in this case are about 81% positive for cancer. As you can imagine, you get down to 4 3s and 2s, it drops considerably. PIRATS 4s are about 50-50 in this series. I will say that there is published data to support that PIRATS 5 detection rates can be lower than 81%. But I think that, again, we try to build the best machine possible and go forward. The reason why I put my number on 81% is because if a PIRATS 5 lesion is biopsied and not found cancer, as I'll show in the next few slides, that bothers me in my practice. So this is an example of a young man, 68, rising PSA. As a urologist, you understand this doesn't make sense. What's going on? Biopsy, biopsy, biopsy. Even saturation biopsies show no cancer. And the MRI gives you the reason. The reason being is because there's an anterior tumor. We've all seen this in our practice. It's very suspicious for cancer, PIRATS 5, and this capsular bulge makes you think this has got to be a tumor. And yet the pathology reveals no cancer. And at the time when we found no cancer, we worried, could there be a mimic to cancer on PIRATS 5? So we heard from the previous speaker, Tom mentioned a very nice study that actually there's no inflammation. So now you have no cancer and no inflammation. And the inflammation you would almost happy to have in this case, because if inflammation, and especially granulomatous prostatitis, and for those who are in their residency, this is an in-service question, quite a lot in many years that we now is on the in-service. These mimics we're happy to find because it can account for a high PSA. It can account for an MRI lesion, looks very aggressive. And of course, it's a benign condition. But in this case, they're both negative. And so what's the next step? At a time when we were taught to re-biopsy high-grade PIN, and we've learned that it's not so important. At a time when we were taught to re-biopsy ASAP, and now it's maybe not as imperative. This is the time when we have to re-biopsy this lesion. Because the PIRATS 5, as we know, is going to be either a mimic of cancer with inflammation or an aggressive cancer, or at least a positive biopsy cancer, and we have neither in this case. And this is where I have major concerns that the location of this tumor lent it to be missed by my biopsy technique. And one could argue that what happens is, as we do a transrectal biopsy, this needle could come off plane. Needles are beveled. As we put them through the tissue, they can deflect. And if the registration is poor, you don't even know you missed it. On your software platform, it looks like you hit it, but you did not. And so therefore, the pathology is very important. We can go through a whole session maybe next year on techniques to avoid these pitfalls. I don't have the time today to go through this. I have a lot of speakers behind me, more senior to me, who need to be up on this podium. But I'll have to say that if at least keep in mind, you have to do that. Now, I always like to put in the organizer's work, and Dr. Plasek referenced this. So this is his poster at Duke, and got it yesterday from Rajan. They were fantastic work. I want to highlight the fact that this was yesterday's kind of fits in perfectly with this lecture. So what they're saying is Tom alluded to it, that the PIRATS 5 version 2 scoring system could be part of the problem. But look, still, PIRATS 5 tumors, highly concordant when you have a cancer, but it's not perfect. And when they went to surgery, that's a little difference right there. What they found out is that this discordance is troublesome. It may be a scoring system, but don't ignore it. And the take-home message is that size is a factor. And maybe the PIRAT scoring system version 2 is pushing the 5s when they're really 4s. But regardless of what you have, it is warranting a rebiopsy. So in conclusion, I think there's no doubt that the radiology community can improve in standardization of the vendors that provide the MR technology for prostate cancer. They can improve how they run the sequences to perform the imaging. They can improve how each patient is managed with the endorectal coil, or at least avoiding the gas in the rectum. But there's no doubt that we have to own that the biopsy technique can be improved. And we are as to blame if we don't find cancer. And then the take-home message for PIRATS 5, if you believe that's the case, you have to go back and rebiopsy it. Thank you.